physical examination of the newborn infant is an essential component of the overall assessment process. Other essential components include obtaining the family health, maternal and labor and delivery history, the gestational age assessment of the neonate, and the evaluation of the neonate's biophysical, clinical, and laboratory data obtained prior to the examination. This videotape will focus on the actual physical examination process. An examination will be demonstrated on both a full-term and preterm newborn. During the exam demonstration, normal physical findings and common variations will be discussed. However, the emphasis of this program will be on the components of the examination process and the techniques for examination. There are 5 basic techniques used when performing a physical examination: observation, auscultation, palpation, percussion, and transillumination. In the normal or well newborn, the techniques of observation, palpation, and auscultation are routinely employed. Percussion is used most often in older children and adults and will not be discussed in this program. Transillumination may be used in the neonate to evaluate for free air in body cavities such as the chest, to help differentiate fluid-filled cavities from solid tissue such as in the scrotum or over the anterior fontanelle, and to help locate arteries for puncture. Other methods of evaluation are used in the neonate, such as the sense of smell. Taking body using the use of the ophthalmoscope will be discussed under examination of the eye. The physical examination presented in the film will focus on observation, auscultation, and palpation of each body system. In general, the practitioner must be opportunistic in the approach to examining a newborn. Since newborns will cry readily when disturbed, it is important to perform the components of the examination that require the infant to be quiet first. Therefore, we recommend that the examiner carry out a brief period of observation without manipulation first. This should be followed by auscultation of heart, lung, and bowel sounds, since it is necessary that the infant be quiet for accurate auscultation. We recommend then that the examiner proceed to palpate pulses and perform the abdominal exam, which may result in an agitated infant. During these initial steps, the examiner should take note of the infant's state, tone, and spontaneous and elicited muscle movements to gather data regarding the neurological system. This will allow the examiner to compare neonatal responses as the neonate progresses through various state changes. Once these initial steps have been completed, the examiner may modify the exam to meet the needs of the infant. The most organized approach is to proceed with a head-to-toe flow, skipping those areas that have already been examined. In this program, a complete examination of a full-term newborn will be demonstrated first using the head-to-toe approach. More detailed discussions of technique, common variations, and anatomic landmarks will be incorporated into this section. This will be followed by an examination of a preterm neonate, using a more realistic sequence for a newborn. For the full-term infant examination, 2 infants will be used, a 5-day-old female and a 3-day-old male infant. Views of both infants will be used interchangeably for this demonstration. To begin the exam, the practitioner will observe the neonate in the resting state. You will note that the neonate is pink centrally and peripherally. This infant is lying in a fully flexed posture, which is normal for a full-term baby. The infant's respiratory effort is not labored. There are no audible grunting sounds. After opening the shirt, you will note chest movements in greater detail, as well as the activity of the precordium. At this time, the practitioner will begin the head-to-toe examination. To examine the head, the practitioner initially evaluates the shape and size of the head relative to the body. The practitioner measures the occipital frontal circumference using a non-stretchable measuring tape. The measurement is then plotted on a standard growth chart to determine if it falls within the normal range based on gestational age. The shape of the head may vary greatly depending on intrauterine positioning, mode of delivery, and degree of molding. To examine the head more closely, the practitioner takes the head in both hands and inspects the scalp and hair. If the infant has a large amount of scalp hair, it is particularly important that all areas are thoroughly inspected so that lesions are identified. The most common form of trauma to the head is a caput succedaneum. This is edema of the scalp, usually located over the presenting part of the head. A caput is noted just after birth, pits on pressure, and typically crosses suture lines. A cephalohematoma is a collection of blood underneath the periosteum, which lines the skull bone. A cephalohematoma generally has clearly demarcated borders coinciding with the skull bone that it overlies. A cephalohematoma may not be evident right at birth. Suction devices to assist delivery may cause trauma to the head. The imprint of a Kobayashi suction device is demonstrated on this infant. A scalp abrasion is demonstrated here, and a laceration of the scalp is noted on this infant. Next, the fontanelles and suture lines are palpated. The cranium is composed of 7 bones, which are soft, and usually separated at birth. The sutures separate the 7 cranial bones. The coronal sutures extend from ear to ear, separating the frontal and parietal bones. The sagittal suture separates the 2 parietal bones, and the lambdoidal suture separates the parietal bones from the occipital bone. The metopic suture extends midline down the forehead, separating the 2 frontal bones. The sutures are palpated along their full length and described as normal if they are approximated and mobile. Mobility is assessed by placing 2 fingers on either side of the suture and pressing down alternately. Bone edges on either side of the suture should move. Sutures may be split up to 1 centimeter or slightly overlapping, depending on the degree of head molding. Rigid, immobile, or widely split sutures require further evaluation. Most infants are born with 6 fontanelles, but the most prominent are the anterior and posterior fontanelles. The practitioner palpates the anterior and posterior fontanelles, noting size and whether the fontanelles are flat or bulging. The size of the fontanelles varies greatly, depending on the degree of head molding. The anterior fontanelle is measured diagonally and varies from barely palpable to 4 to 5 centimeters across. The posterior fontanelle is smaller than the anterior fontanelle and may be barely palpable with the fingertip. The face is examined next for shape, symmetry, lesions, and movement. Asymmetry of the face may result from injury to the 7th cranial nerve. The 7th cranial nerve is distributed along the face and in front of the ear. Forceps trauma is the most common cause of injury. You will note that facial movements are symmetrical on this infant. 4 components should be evaluated. The nasolabial fold should be present. Both eyes should open and close. The corners of the mouth should move, and the tongue should move on both sides. All 4 components are present in this infant. The eyes are examined for placement and size of the palpebral fissure. The palpebral fissure is the elliptical space created when the eyelids are open. The distance between the outer canthus of both eyes can be divided equally into thirds, with 1 palpebral fissure length fitting between the 2 eyes. Small palpebral fissures, widely or closely spaced eyes, and eyelid defects may all be associated with syndromes or chromosomal anomalies. An epicanthal fold is a fold of skin extending from the upper to the lower lid on either side of the nose. Epicanthal folds are common in Asian infants, but may suggest Down syndrome in other ethnic groups. To examine the eye, the infant may spontaneously open the eyelids, or the examiner will need to open them. The practitioner first inspects the iris, which should completely surround the pupil. The sclera should be white unless the infant has experienced a conjunctival hemorrhage during the delivery process. The practitioner next uses the ophthalmoscope to assess the pupil response and red reflex. The ophthalmoscope is set on 0, and the white beam of light is directed at the pupil while the practitioner looks through the ophthalmoscope with 1 eye. The practitioner should observe that the pupil is round and will react by constricting to the light source. A clear, round red color, the red reflex, should also be noted. The ear is examined for shape, position, size, associated anomalies, and for drainage. An otoscopic examination is not performed in the newborn period. Pits or skin tags or other external abnormalities should alert the practitioner to look for other anomalies and to assess hearing function. To evaluate ear position, the tip of the auricle or pinna should cross the eye-occiput line. The angle formed by this line and the long axis of the ear should be almost vertical. The nose of the neonate should be symmetrical and placed in the facial midline. While its shape and size may be familial, it will appear flatter than that of the adult. When inspecting the nose, there should be no visible movement or flaring of the nares with breathing. There is no flaring noted on this neonate, and the nasal septum is centrally placed. The lower turbinates are visualized. To assess patency of the nasal passages, the examiner may occlude each nostril while listening for respiratory sounds from the opposite nostril. If any obstruction is suspected, a soft 5 French catheter should be passed through each nostril to establish patency. The examination of the infant's mouth and throat should begin with inspection of the lips and mucous membranes. They should be pink and slightly moist. A bluish color around the mouth, circumoral cyanosis, may be present and is normal right after birth. The mouth should be assessed for size, shape, and lip fullness. Inspection of the inside of the mouth is most easily done with the infant crying or with a tongue blade and light source. Probing of the lips and gums usually results in spontaneous opening of the mouth. The hard and soft palate, gums, mucous membranes, tongue, oropharynx, and uvula should all be visualized. The hard and soft palate should be smooth and without clefts. Small white accumulations of epithelial cells called Epstein's pearls may be visualized on the hard palate or gums. They are a normal occurrence and will disappear spontaneously. Although not present on this neonate, bluish-white swellings called mucoceles or ranulas may be present. These represent benign mucus or salivary gland retention cysts and usually spontaneously disappear. Infrequently, natal teeth may occur, usually at the position of the lower incisors. This neonate has 2 teeth that have not yet erupted through the lower gum line. The presence of excessive secretions should be noted and is considered abnormal. If there is any question about the patency of the esophagus, an orogastric tube should be passed to the stomach. At this time, the rooting and the suck reflex may be assessed. The rooting reflex is assessed by stroking the cheek outward from the corner of the mouth. The suck reflex may be assessed with a pacifier or gloved finger. The neck should be inspected and palpated for the presence of masses, cysts, or sinus tracts. Lateral and vertical range of motion should be assessed. The thyroid gland is located on the midline and is usually not palpable unless it is enlarged. The overall physical structure of the chest is assessed next. Reference lines in describing physical findings on chest and lung exam include the midsternal line, which bisects the suprasternal notch, the nipple line, which is the horizontal line drawn through the nipples, the mid-clavicular line, which is the vertical line drawn through the right and left clavicle, and the anterior axillary line, which extends vertically from the anterior axillary fold to the diaphragm. To begin the assessment of the lungs, the practitioner evaluates the respiratory rate and the quality of respirations. This infant demonstrates a normal breathing pattern and rate. Newborn respirations are frequently described as diaphragmatic. This is because as the diaphragm contracts and moves down to create a negative intrathoracic pressure, the lower thorax pulls in and the abdomen bulges with each respiration. In addition, neonates have a very compliant chest wall. Although not demonstrated by this infant, you may note mild retractions between the ribs. Auscultation of breath sounds should occur next, since further inspection will require manipulation of the neonate, which may cause the infant to cry, interfering with auscultation. Assessing the neonate's breath sounds should be done in an organized, sequential manner, beginning at the top of the chest and moving from side to side. Breath sounds should be symmetrical throughout the lungs. Breath sounds in the lower lobes of the lungs can be assessed adequately only through the infant's back, although this is not always possible or desired in sick neonates. Breath sounds in the newborn should be assessed for pitch, intensity, and duration. Normally, breath sounds can be described as vesicular. This describes breath sounds that are soft, short, and low-pitched during expiration and louder, longer, and higher-pitched during inspiration. These sounds are normally found over the entire chest, except over the manubrium and trachea. Shortly after birth, it is not unusual to hear rowels as the neonate continues to reabsorb fetal lung fluid from the alveoli. After a thorough inspection of the chest and auscultation has been performed, the chest circumference is measured at the largest diameter. Palpation of certain areas of the chest complete the chest exam. These areas include the ribs, sternum, nipples, and breast tissue. The nipples and breast tissue should be inspected and palpated to evaluate for the presence of hypertrophy, fissures, secretions, or masses. Assessment of the neonatal cardiovascular system should begin with observation of the infant's general appearance. This should include inspection of the infant's color, observing for signs of central cyanosis, breathing patterns, activity level, perfusion and mottling, and recognition of extracardiac anomalies that may be associated with congenital heart disease. Once this general inspection is complete, closer inspection of the precordium and apical impulse is necessary. The precordium is the area on the anterior chest wall under which the heart lies. The apical impulse represents the movement of the left ventricle during contraction. It is usually visualized in the neonate in the fourth intercostal space, at approximately the midclavicular line. The examiner should note the general activity of the precordium and the position of the apical impulse. A hyperactive precordium in a full-term neonate, especially after the first few hours of life, or shifting of the apical impulse, may indicate congenital heart disease. There is no visible precordial activity noted in this infant. Once inspection of the precordium is complete, light palpation of the precordium can yield further information about the cardiovascular system. The apical impulse may be further defined using the fingertips. In addition, the PMI, or point of maximum impulse, should be palpated. The PMI and apical impulse may be the same, but sometimes during the first few hours of life, the PMI will be localized at the fifth intercostal space along the left sternal border, or substernally. This finding is normal at this time and represents the right ventricular predominance found in the normal neonate. Palpation is also useful in helping further define the perfusion state of the neonate. This is done by checking capillary refill. A finger is lightly pressed against the neonate's skin in a central and peripheral area. Blanching is determined, and the number of seconds required for the color to return to the skin is counted. This infant demonstrates a normal capillary refill of less than 3 to 4 seconds. Finally, palpation is used to evaluate the peripheral pulses. Using the index finger, the brachial, femoral, radial, posterior tibial, dorsalis pedis, and popliteal pulses can be palpated. At a minimum, the brachial and femoral pulses should be palpated and compared. The rate, rhythm, strength, and character of the pulses should be assessed. The volume of the peripheral pulses is graded on a scale of 0 to 4+. 0 represents an absent pulse, and 4+ represents the strongest pulse. The absent or bounding pulses should be noted and may indicate specific cardiac lesions. After inspection and palpation, the examiner uses a pediatric stethoscope to auscultate the neonate's heart. The infant should be quiet and the stethoscope warmed. The stethoscope is first placed over the chest and the heart rate is auscultated. The 4 auscultatory areas of the heart are examined next. These areas include the aortic, which is the second intercostal space at the right sternal angle, the pulmonic, which is the second intercostal space at the left sternal angle, the tricuspid, which is the fourth intercostal space at the left sternal angle, and the mitral area, which is the fifth intercostal space at the midclavicular line. In addition to these areas, valuable information about the cardiac status may be obtained from examining the left and right infraclavicular areas, the left and right axillary areas, the right chest, and both sides of the back. If a murmur is heard, the anterior fontanelle and the liver should be auscultated to evaluate for arteriovenous fistulas, which are most commonly found in these two areas. During auscultation of these areas, it is important to evaluate the heart sounds for rhythm and regularity and the presence of murmurs. Any irregular rhythm must be noted and carefully assessed for frequency of occurrence and any recognizable repetition. There are two normal heart sounds referred to as S1 and S2. S1 is heard with the closure of the mitral and tricuspid valves, and S2 is heard with closure of the aortic and pulmonic valves. S1 occurs at the onset of ventricular contraction and will be heard best at the apex of the heart. S2 is usually heard loudest at the base of the heart. Adventitious or extra heart sounds, such as splitting of S1 or S2, or S3 and S4 gallops and clicks, can also potentially be heard in neonates. The ability to hear these in neonates takes much practice due to the rapid rate of the newborn's heart and will not be discussed further here. Cardiac murmurs are abnormal sounds created by turbulent blood flow. When evaluating a murmur, it is important to determine 5 characteristics: location, intensity, timing, pitch, and radiation. Most murmurs are usually located below where they are best heard. Therefore, a murmur from a ventricular septal defect would best be heard at the lower left sternal border. The intensity of a murmur is graded on a scale of 1 to 6, with grade 1 being barely audible and grade 6 heard with the stethoscope just off the chest. The timing of the murmur refers to where in relation to S1 and S2 the murmur occurs. The pitch refers to the tone of the murmur, and radiation identifies all locations where the murmur can be heard. A murmur from a patent ductus arteriosus will radiate from the upper left sternal border to the back of the baby following the branching of the pulmonary vessels. The abdominal assessment should proceed in an orderly fashion, beginning with the least intrusive technique. First, inspect the abdomen for movement and shape. Normal movements are synchronous with chest movements. Intermittent peristaltic movements become visible after the first hour of life. The shape of the abdomen appears slightly distended due to poor muscular tone. The midline of the abdomen is normally closed, but the diastasis recti, a gap between the rectus muscles, is a common finding in otherwise healthy infants. Signs of diastasis recti are a palpable midline gap and a visible bulging at the site in the crying infant. The umbilical cord should be examined for the number of vessels, color, odor, drainage, and thickness. Normally, the umbilical cord is bluish-white and gelatinous at birth. There should be 2 arteries and 1 vein noted. The arteries are thick-walled with a very tiny lumen. The vein is thin-walled with a gaping lumen. The cord darkens and shrivels as it dries, falling off within 10 to 14 days. The examiner should listen to all 4 quadrants of the abdomen. Bowel sounds become audible within the first 15 minutes after birth. The sounds have a metallic tinkling or rumbling quality. Gently palpate the abdomen with warm hands. Observe for pain response. Generalized palpation of the abdomen, covering all 4 quadrants, should be done to detect possible identification of masses. With pads of the fingertips and the fingers together, begin with a shallow, smooth, gentle pressure. Then proceed with deeper palpation. To facilitate palpation of specific organs, flex the infant's knees and hips with one hand and use the free hand to palpate the abdomen. This maneuver relaxes the abdominal musculature. To palpate the liver, Place the index finger just above the groin, parallel to the right costal margin, and with a gentle compressing motion, gradually move the finger upward until the liver edge is felt. Normally, the liver edge is felt 1 to 2 centimeters below the right costal margin at the mid-clavicular line. This liver is palpated 1 centimeter below the right costal margin. The normal liver is smooth and firm, with a sharp and well-defined edge. A similar approach is used on the left side of the abdomen to palpate the spleen. Normally, the spleen is not felt. Kidneys are sometimes difficult to palpate. The ideal time to palpate normal kidneys is immediately after birth. Place one hand under the infant's flank and press downward with the other hand. Because the liver may interfere with palpation of the right kidney, the left kidney is more easily palpated. Large amounts of stool in the colon will also interfere with palpation. Examination of genitalia in the term female infant should reveal the labia majora to be large and may completely cover the clitoris and labia minora. The urethral meatus is often difficult to visualize. It is located directly below the clitoris. The vaginal opening should be examined next. There should be a fingertip space between the vagina and the anus in the term infant. A whitish serosanguinous or bloody vaginal discharge may be present during the first few days after birth. This normal discharge results from withdrawal of maternal estrogen absorbed by the fetus. Another normal finding is a hymenal tag. The tag disappears in several weeks. Examination of the male genitalia begins with assessing the length and size of the penis. The prepuce, or foreskin, normally covers the entire glans and is quite tight. However, this infant was recently circumcised, so we will demonstrate retraction of the foreskin during the preterm infant examination. The urethral opening, or meatus, should be located at the tip of the glans of the penis. The scrotum should be inspected for rugation, color, and size. This term male infant has rugae throughout the scrotum. The scrotal sac should be palpated for testes. The testes in a term male should be palpated low in the scrotum as they are in this neonate. The perianal area and anus are inspected. It is also important to note whether the infant has stooled to further evaluate rectal patency. The skin is examined during the process of assessing each body system so that it is integrated throughout the examination. For the novice, however, it may be easier to look at the skin in total at the end of the examination. The skin is both inspected and palpated. For a thorough skin examination, the infant must be completely undressed. We will start the examination of the skin with general assessment parameters, followed by more specific common newborn variations. At the onset of the examination, infant's color and perfusion. The neonate should be generally pink and may demonstrate acrocyanosis during the first 48 hours of life. Jaundice or a yellowish discoloration of the skin should not be present during the first 24 hours of life. It is commonly present in full-term neonates after 24 hours of age and is generally noted to progress in a head-to-toe manner. General hydration and intrauterine nutrition may be assessed by examination of the skin. Growth-retarded infants who have lost subcutaneous fat tissue in utero will appear to have loose skin since the subcutaneous layer is diminished. Vernix caseosa, a greasy white yellow material, may cover the neonate at birth. Vernix is composed of sebaceous gland secretions and exfoliated skin cells. In a term neonate, vernix may be noted in the skin folds. Lanugo is a fine downy type of hair that covers the body of the fetus beginning at approximately 20 weeks gestation. Much of it should be receded by 40 weeks gestation, although you may still observe it over the shoulder blades and back. Once these general parameters have been assessed, the practitioner should turn her attention to inspecting for specific lesions. In doing so, the practitioner needs to inspect under the arms, between the neck folds, and in all crevices so that lesions are not overlooked. The following slides demonstrate some of the more common newborn variations. Erythema toxicum is a macular rash with yellow-white papules. Milia are pinhead-sized white papules commonly seen over the nose and chin and represent accumulation of sebaceous gland secretions. A nevus simplex, commonly called a stork bite, is a pink macule seen on the upper eyelids, the glabella, and the nape of the neck. They are composed of distended capillaries and generally fade over time. A Mongolian spot is a gray or bluish discoloration of the skin seen commonly in African American, Oriental, and Hispanic infants. They may fade with time. A pigmented nevus is a dark brown or black macule. Many are benign, but malignant changes may occur in up to 10% of them, so that surgical excision may be considered during the first year of life. Petechiae are tiny reddish-purple lesions in the superficial layers of the epidermis. They may normally be found over the presenting part as a result of trauma. Petechiae in other parts of the skin are abnormal and may indicate thrombocytopenia. The examination of the skeletal system includes assessment of the extremities, hips, and spine. A general inspection noting areas of erythema, swelling, or bruising which could indicate fractures, and inspection of the infant's overall posture is carried out first. The term infant generally lies in a symmetrical position, with limbs flexed and the legs partially abducted at the hips. The head rests in the midline, either slightly flexed or turned to one side. The upper extremity exam should include the bones of the shoulder girdle, as well as the humerus, elbow, forearm, and hand. Shoulder movements should be symmetrical and free. The clavicles should be palpated along their full length. Swelling or crepitance near or over the clavicles may indicate fracture of the clavicle, as would any restriction of movement. The humerus, elbow, forearm, and wrist should be inspected and palpated. Any pain or mass formation may be suggestive of trauma or fracture. Note the general length of the arms. Gross deformities may indicate absence of the humerus, radius, or ulna. The elbow and wrist should be checked for range of motion. Examination of the hands should include notation of shape, size, and posture, while the fingers are examined for length, shape, and number. The fingernails should be smooth and extend to the fingertips. Presence of extra digits is referred to as polydactyly. Supernumerary digits are extra digits superimposed on the pre-existing digits. Syndactyly refers to two or more digits fused together to a varying degree. Macrodactyly refers to enlarged digits. Clinodactyly is the overlapping and incurving of digits. The palm of the hand should be examined. The presence of a simian crease, one transverse crease across the palmar surface, may be normal but can also be associated with Down syndrome and other congenital defects. The spine and back can be best examined with the infant in the prone position or in ventral suspension. The spine should be palpated along its full length from the base of the skull to the coccyx. The spinal column should be straight. Close inspection along the spine should include observation for cysts, hair tufts, masses, hemangiomas, dimples, or sinus tracts. Abnormalities such as a myelomeningocele or a sacral teratoma are obvious. The lower extremity skeletal exam includes the hips, femur, tibia, fibula, knee, ankle, and foot. The hip exam in the newborn period is very important for the detection of congenital hip dislocation. In assessing for congenital hip dislocation, inspection consists of looking for symmetry of leg lengths and skin folds in the gluteal and femoral regions. Asymmetrical leg movement or extreme hip flexion are also suspicious. There are two maneuvers used to assess for congenital hip dislocation: the Barlow's maneuver and Ortolani's maneuver. To perform the Barlow maneuver, the examiner should place their longest finger over the trochanter while the thumb grasps the medial aspect of the femur. With the knee and hip flexed, the examiner uses a pistoning maneuver to try and dislocate the femoral head from the acetabulum. When pistoning down, gentle outward pressure is placed by the thumb on the inner thigh. This maneuver is immediately followed by the Ortolani maneuver, which involves abducting the thigh to the table. The thigh should be able to be abducted almost fully to the table. Each leg is maneuvered individually and then bilaterally. When congenital hip dislocation is present, the femoral head will be felt and sometimes heard to click or clunk as it exits and enters the acetabulum at some point during the pistoning maneuver or in the 90-degree abduction arc. Any limitation in abduction is also suggestive of congenital hip dislocation. Generally, the appearance of the extremity positioning at birth can reflect intrauterine positioning, with the newborn's lower extremities often externally rotated and bowed, with everted feet. The upper and lower legs, as well as the knee and ankle joints, should be inspected and palpated. Ankles and feet should be noted in their resting position, then examined for range of motion. Structurally abnormal feet and ankles will have limited range of motion and will resist dorsiflexion. Metatarsus adductus is a common newborn variation and generally secondary to intrauterine positioning. The forefoot is adducted or turned in, but able to be passively straightened with manipulation. A clubfoot is diagnosed when there is severe plantar flexion at the ankle, inversion at the heel, and adduction of the forefoot. This is a rigid deformation requiring orthopedic intervention. Assessment of the neurological status is actually carried out throughout the entire examination process. There are 7 areas to evaluate for a detailed neurological assessment. Those are state of alertness, posture, muscle tone, muscle strength, spontaneous and elicited muscle movements, cranial nerves, and reflexes. The infant in this demonstration has progressed from a very sleepy state to very alert and active state. The infant moves all 4 extremities spontaneously. A few beats of ankle clonus are normal for a neonate. This neonate demonstrates good tone and strength by full flexion of the extremities and hips and good recoil of the arms and legs. When pulled to a sitting position, the baby will briefly hold his head in alignment with the body, and then the head will flop to the chest. For most newborn exams, the practitioner should focus on level of alertness, tone, strength, muscle movements, and symmetry of movements. Complete testing of all cranial nerves is not necessary for most infants. It is most common to test the rooting and suck reflexes, facial symmetry, and gross hearing. Rooting, sucking, and facial symmetry have already been demonstrated. The startle response to a loud noise is used to grossly evaluate the auditory nerve. There are many reflexes that may be evaluated in the newborn. Some are developmental and will disappear over time. These are the rooting and sucking reflexes already demonstrated. The palmar grasp. The examiner strokes the inside of the hand, and the neonate should curl his fingers around the examiner's finger. The examiner is evaluating for the presence of the reflex, the strength, and symmetry. With traction, the full-term newborn should hang on to the examiner's finger. The asymmetrical tonic neck is demonstrated spontaneously by this infant. To elicit the reflex, the head is turned to one side. The arm and leg on that side extend, and the arm and leg on the opposite side flex. It is not uncommon for the newborn to assume this position on his own. However, it should not be persistent or rigid. The Moro reflex is elicited by rapidly dropping the infant's head a few centimeters onto a cushioned surface, such as the mattress or the practitioner's hand. The infant should respond with a brisk extension of the arms and opening of the hands. This is followed by adduction and flexion of the arms, closing of the fists, and sometimes a cry. The examiner evaluates for the presence and symmetry of the Moro reflex. There are many other reflexes which may be evaluated in the newborn, but are not part of the routine for the normal newborn examination. The biceps and patellar reflexes are evaluated by tapping over the tendon. The tendon is placed under a slight stretch by the examiner's finger, and a brisk tap with the finger usually elicits a contraction and jerk response. This completes the examination of the full-term neonate. We will now demonstrate a physical examination on a preterm infant. This session will be carried out without interruption and in a more realistic sequence. The maneuvers requiring the infant to be quiet will be performed first. This is a 14-day-old, 33-week gestational age male infant. He was delivered prematurely, secondary to a suspicion of chorioamnionitis and intrauterine growth retardation. His neonatal problems included mild hyaline membrane disease, hypotension, and hyperbilirubinemia. He is now a stable, growing, premature infant and weighs 1,450 grams. We will begin the examination with a brief observation period, noting color, perfusion, state of alertness, overall posture, and degree of extremity flexion as an indicator of tone. This infant is pink, well perfused, with a normal capillary refill. His overall posture is semi-flexed, demonstrating a moderate degree of tone, which is appropriate for his gestational age. The infant is alert and able to fixate on and follow an object for a brief period of time. To evaluate the cardiovascular and respiratory system, the examiner will begin by observing the chest and precordium, noting the point of maximal impulse if visible. The precordium is palpated next. Then the heart and lung sounds are auscultated. The stethoscope is briefly warmed with the examiner's hands. The examiner assesses the 4 primary areas: the aortic, which is located at the upper right sternal border; the pulmonic, which is located at the upper left sternal border; the tricuspid, which is located at the 4th intercostal space along the left sternal border; and the mitral area, which is located at the 5th intercostal space along the midclavicular line. Additional areas to auscultate include the infraclavicular and axillary areas, the right side of the chest, and the back. During auscultation, the examiner notes the general heart rate and the quality of the first and second heart sounds, as well as any extra or abnormal sounds. The area over the anterior fontanelle and liver are also assessed for bruise. There are no murmurs auscultated, the heart rate is 150, and the S1 and S2 are normal. The lungs are auscultated next, proceeding in a side-to-side fashion and over the back. The lung sounds in this infant are clear and equal, with a respiratory rate of approximately 40 breaths per minute. The brachial, femoral, and pedal pulses are palpated next. The brachial and femoral pulses are palpated simultaneously and compared. The pulses in this infant would be described as 1+. To inspect the abdomen, the examiner observes the abdominal movements and shape. This abdomen is slightly rounded and full. There is no evidence of a diastasis recti. The umbilical area is inspected. Since this neonate is 14 days old, the cord has fallen off with a clean umbilical area noted. The examiner listens to all 4 quadrants of the abdomen for bowel sounds. Bowel sounds are audible in all 4 quadrants in this infant. Generalized palpation of the abdomen is performed next. All 4 quadrants are palpated. The knees are flexed if the infant tenses his abdomen. The liver is palpated on the right, beginning with light palpation in the lower right quadrant. This liver edge is felt at approximately 2 centimeters below the right costal margin. The spleen is palpated on the left using the same technique. The spleen is not palpated in this neonate. Both kidneys are palpated using the bimanual technique. One hand is placed under the flank of the infant, and the other hand palpates over the flank. The lower pole of both kidneys may be palpated. At this time, the practitioner has completed most of the components of the exam requiring that the infant be quiet. She then moves to evaluate the infant in a head-to-toe sequence, skipping the areas already examined. The practitioner takes the head in her hands and inspects and palpates the full circumference of the head. The coronal, sagittal, and lambdoidal sutures are palpated. The anterior fontanelle is assessed for size and fullness. The posterior fontanelle is palpated as well. The face is examined next for shape, symmetry, and lesions. The eyes are examined for placement and palpebral fissure size. The eyes are opened manually to inspect the sclera and iris. The examiner next assesses pupillary reaction and presence of the red reflex using the ophthalmoscope. The ears are inspected for form, shape, and anomalies. The position of the ear to the eye occiput line is evaluated. The ear position is normal in this infant because it falls within the eye occiput line. The nose and nares are inspected. There is no flaring or septal deviation. Patency of the nasal passages is assessed by occluding one nares while auscultating for air sounds from the other. For accurate assessment, the mouth should be closed during this procedure. Using a tongue blade and a light source, the examiner probes the lips and gums of the neonate. The inside of the mouth is inspected. The rooting reflex may be elicited next along with the suck reflex. The neck is inspected and palpated. Lateral and vertical range of motion are then assessed by rotating and flexing the head. The area of the thyroid gland is palpated next. Moving to the chest area, the clavicles are palpated along their full length. The ribs and the sternum are palpated while inspecting the chest for lesions. The nipples and breast tissue are inspected and palpated. This neonate has very little breast tissue due to his gestational age. Finally, the chest circumference is measured. Since the examiner is inspecting the chest, it is most efficient to complete the examination of the upper body at this time. The arms are palpated and the range of motion of the shoulder, elbows, and wrists are evaluated. The axillary area is inspected. The hands, digits, and nails are also inspected and palpated. At this time, spontaneous arm flexion and recoil are assessed. Finally, the grasp reflex may be elicited at this time. Since the abdomen has already been evaluated, the genitalia and anus are examined next. The penis is inspected and the foreskin is retracted. The meatus is properly located at the tip of the penis. Both testicles are descended and are palpated high in the scrotum. The anus is inspected along with noting whether the infant has stooled. At this time, the lower extremities are evaluated. Movement of the legs is random and symmetrical. The legs are inspected for symmetry in length and skin folds. The legs are palpated and the knee and ankle joints are assessed for range of motion. The feet and toes are normal without evidence of metatarsus adductus. Assessment of clonus may be carried out next. 3 to 5 beats of clonus are expected in this infant. The patellar jerk reflex may be elicited at this time, although the response varies with the gestational age and the state of the baby. To examine the hips, the practitioner evaluates one hip at a time, performing the Barlow's maneuver first, followed by the Ortolani maneuver. Then both hips are evaluated simultaneously. There is no evidence of subluxation or dislocation in this neonate. Throughout the examination, the practitioner has observed changes in the neonate's state, general tone, and symmetry of movements, along with skin color and any abnormal lesions. To complete the evaluation of the skin, the practitioner inspects the skin thoroughly on the front and back. While the baby is on his abdomen, the back is inspected. The full length of the spine is inspected and palpated. If the lung and heart sounds have not already been auscultated on the back, they may be auscultated at this time. The baby may then be held in ventral suspension to evaluate neck extension and strength of the spine. The truncal incurvation reflex may be assessed as well. At this point, most of the exam has been completed with the exception of a few neurologic components. The moral reflex in this neonate is evaluated by a flexion and quick drop of the head. Note the brisk and symmetrical outflinging of the arms. The preterm neonate may lack the strength to bring the arms back to the center. The neck extensors and flexors are assessed in the pull to sit maneuver. The neonate is pulled to a sitting position by traction on the arms. Support is given to the shoulders of this preterm neonate. A significant amount of head lag is noted in this neonate, which is to be expected given his prematurity. This completes the examination of this neonate. Physical examination of the newborn requires well-developed observation skills on the part of the practitioner as well as an opportunistic approach. The state of the baby will significantly impact your interpretation of the examination and your ability to complete it adequately. Multiple evaluations over time may be the most effective means of fully evaluating the newborn, particularly since significant physiologic changes are occurring as the neonate makes the transition from an intrauterine to an extrauterine environment.